question that had come in is one of the areas that I absolutely love. Now, if you've been with us for a while, I say that all the time. I know you get tired of me saying it. However, it is an area that I really do enjoy, and that's one of the areas that I'm working outside of CCO in is documentation improvement, CDI work for a university hospital. So it's a teaching hospital in addition. And there's always areas for documentation to be improved. Now, I'm going to give you a brief overview of what you can do and some areas to look at. But each one of these areas that I'm going to talk about is able to be broadened. I could do a whole presentation on just one of these many things that I'm going to tell you about. So this request had come in. The person had asked that their name not be shared. Our intern was Natalie Kuhn, and just shout out to our interns. They do a fabulous job. We'll talk more about our internship later. And I also wanted you to know that if you are in our academy or you're in the CCO club, you always have the ability to come back and look at these discussions and comment on them and carry on the conversation even after the webinar. So the question specifically was, how can I help educate my physicians to document to make it easier for me to code for them? And that's basically what we're doing. We're working as a team to allow the information to be translated. It's two different language, clinical speak being translated into a code set, and then it's for statistical purposes. We code for statistical purposes. It happens to be a convenient way to get paid, and money is the greasy wheel. So that's what everybody talks about. But if we do not capture the correct codes in CPT and the correct diagnoses at the highest specificity, we're really not reflecting our patient population or the work that our clinicians are doing. So to effectively do that, you can have a toolkit, and the toolkit can be fun and effective. And here's going to be some educational strategies. The ultimate guide is what we're going to give you an idea of how to flesh out to educating physicians for flawless documentation. We're going to be the ones to transform coding from a chore to a partnership. When I was doing consulting work, and when I still do consulting work on the side for ACOs and things, what I ask them is that if your doctor and your coder are heading towards each other down the hallway, and as soon as they see each other, they both go in two different directions, that's a bad sign. You have to have a good relationship with each other to be effective in an office. It's definitely teamwork. The clinician or the provider, whichever way you want to use the verbiage, need to know that you've got them in making sure that their documentation is translated properly. They didn't go to school for this. They didn't go to school to learn the code sets like we did. And the best way I like to give an example, both to the clinicians and to coders, is, have you ever been in the presence of an ASL translator or talk to somebody who is a certified translator for any language? There is criteria for that. They have guidelines as well. And if you have an ASL translator in a doctor's office, they are not a clinician. They are translating what is being said in that moment. They have rules and guidelines, but they don't understand the disease process. Whereas coders, we understand the disease process. We understand the behind the scenes and what's going to happen after that patient leaves the room. And yet we need to feel confident to be able to ask the clinician, if I don't understand something, be able to say, can you explain how this diagnosis is different from this diagnosis? What am I missing? And then if they explain, say, okay, well, if you document A versus B, then I'll know the difference because you've educated me. So again, having that comfortable relationship with each other is going to be key. The priority, though, is that we both understand the language. We're both experts in our area. The clinician is expert in clinical documentation and the disease process. We're experts in the code sets. Okay. And we're going to partner together to make sure our patient population is and the work that's being done is properly translated. Now, you are not a chart police. That is not your role. It's to be the physician's trusted guide and coding ally, right? So we aren't there with the ruler or the red pen like in school. This is going to cause conflict and distrust. So how do you build that relationship? And what do you let your clinician know that you've got their back, that you're there to assist them? The golden rule really is speak clinical, not just coding. Now, when I was working with Baylor, they had been educating in risk adjustment and diagnoses for over a decade in their outpatient. Usually it's an inpatient thing that most big entities like that focus on, but they were proactive and they started educating the clinicians, and therefore their reimbursement really was elevated in those lump sums that they would get for their patient population from the government. That being said, they learned, and I saw it in practice, that when you're educating the clinician, don't be throwing codes at them. They don't really care about the codes. They have coders to take care of that. Now, in some instances, the physician will drop their own codes, and you're there to audit and clean them up and make sure they're doing the right ones. It depends where you're working. However, for the most part, we translate. So physicians, they're clinically brilliant. Your job is to translate the coding needs into their language. Patient care and medical necessity are the key things that we want to represent. So here's some examples of kind of a pros and cons way to look at it. Instead of saying things in coding jargon, because again, they don't know the code set, they don't have time, it's not in their bandwidth to learn the code set. But for the most part, everybody's working long hours to get the job done, and they want to be enlightened, but they don't necessarily want it forced down their throat or make them be required or responsible for something that they are not brilliant at. And so they'll tell you, I didn't get into medicine to be doing paperwork all day. I don't need to know the codes. So don't give them the codes. Be very careful about what you say. So instead, if you say you need to add more specificity to your ICD-10 codes for diabetes, that is something a coder would say to another coder, right? That's not going to work. Noting that the patient's diabetes with diabetic neuropathy helps us paint a complete picture of the severity and justifies the extended exam and management plan. Now, that's the long version. You can still shorten that up, but you can see the tone is completely different. They will tell you, what do you need me to write? This is how it needs to look. Now, there are rules and guidelines that we fall into and what we can say because we're not clinicians. It's our responsibility to let them know the key phrases and terms and what's available to be translated in the code set, like diabetic neuropathy. Another example is your E&M level doesn't support a 99214. Now, most of the time they know what a 99214 means because there's benchmarks and their superiors and so on. They're tracking that, but their terminology is usually, you didn't get a level 4. You could have gotten a level 5. I'm scared of getting level 5s because I don't want somebody to ding me or have to give money back. That's what they're thinking. The work you did was absolutely complex enough for a 99214 to show the payer. We just need to document your thought process on why you changed the medication due to the side effects. An example of that is primary care putting a patient with hypertension on lisinopril, and the patient tries it for 2 months. they come in with that chronic hacky cough and they realize, hey, this isn't allergies, this is something else. And their friend tells them, you better tell the doctor about that. They go in and they say, yeah, you're right. It's kind of like a 50-50 chance you're going to either get that cough or you're not from lisinopril. So why did you change the medication? Because of the side effects, the cough. Changing a medication ups the level in medical decision making. So that's what we're trying to represent. You didn't document the size of the lesion. Now, this is always problematic. We are always telling the clinician, hey, we need this in the documentation. So instead of that, just remind them, documenting the lesion size at 1.5 centimeter, for example, ensures we code and bill for the exact procedure you performed. Simple as that. You can send these in messages. Now, a brilliant way that I've been a part of and that continue to be effective is a lunch and learn power hour. This is one, you're going to feed them. They seldom have time to eat. They're usually eating at their desk. So if they're going to eat at their desk anyway, why not do a 15-minute presentation every month? Especially if they're in a specialty, to go over and highlight maybe what you've reviewed with them, off of auditing their documentation or improvements that you can show them. And so the key is keep it short. They seldom can commit to an hour. And if you keep it short, that gives them more time to ask questions, or the next time you want to schedule time with them, they know, hey, you only took 15 or 20 minutes. That's great. I can give you that. But if you schedule an hour with me and you take an hour and 10 minutes, I'm not going to let you schedule with me again. I'm going to avoid you. So it's one of those tell them it's going to be 20 minutes and only take 15, things like that. Gamify it. Create a coding Jeopardy with categories like name that diagnosis. This works also with coders. You have a team coding meeting. Or even if you're in an office with, say, a few specialties in a physician practice or some, come up with something where you put a sticky note on someone's shoulder and it has a code on it. And you have to, without looking it up, see how many clinicians can figure out what that code is. And then at the end, you reveal it. You know what I mean? Different codes, or match up diagnoses with codes and stuff. There's all kinds of little things that you can do, but make it fun in the office. But if you get a group together, you could play a quick game. Let them show you how brilliant they are. Another example is an E&M level up or medical necessity mystery, because as an auditor and CDI and doing provider education all these years, sometimes it's a simple statement. You know they're doing it like an independent interpretation of the imaging that was done or the tests that were done. That right there elevates the medical decision making. What if they have an independent historian? The patient's daughter was there and answered questions. That bumps the E&M. They need to know that, so that if someone else is in the room and helps with the history, they need to let us know. By leaving that out, lowers the medical decision making. Keep it short, again, minutes, and always know that you're respectful of their time. Another area is the golden nugget email blast. If you don't like that name, come up with another name where once a week you send an email blast out to your provider/clinicians, just giving them a little golden nugget of knowledge that they may not have been aware of. An example of that is that now we have codes available for classes of obesity, 1, 2, and 3. And here's the BMI levels that reflect that. So if you state that the patient has obesity class 2 or class 3 obesity, that is all we need to be able to pick that proper code versus just stating obesity. So that could be a little nugget that you pass out that week or that month. And if you make it kind of fun, they'll enjoy doing that. Make it engaging. Here's another one, subject line, 57 seconds to better documentation. Say, this week's golden nugget, when you remove a nail, noting avulsion of nail plate, simple, is all we need to code it perfectly. Thanks, team. How brilliant is that? And then you can give them a picture of a grimy nail or something. Most clinicians like pictures. Why is this really helpful? Why does it work? Because it's digestible. It only takes a few moments to read, not overwhelming, and it really consistently reinforces those good habits. And that's what you want. They need to know what to document. And by them documenting it, you're elevating their medical decision making because you know they're thinking it. They just got to be able to get it down on paper. Another area is to create cheat sheets, but ones they'll actually use. Now, I've been involved in doing this a lot, and I would encourage that you leave the codes off. However, sometimes you do need to put the codes on. I would find out what the top 10 codes are, CPT or diagnoses or both. If it's both, do like 5 and 5, and laminate it and hand it to them. Make sure everybody's got one in their office or something small enough that they can carry around in their pocket. Make it sleek, laminated, and I'm sure I see them carrying around the little E&M guides all the time. Top 5, top 10 documentation must-haves for a level 4. Independent interpretation of tests, not reports. Independent historian, SDOHs. How to document lesions, excisions, maybe with pictures. And another example would be your quick guide to linking diagnoses with severity, depression, mild, moderate, or severe. Again, letting them know we need to know. Laterality is usually a common one. They pretty much got laterality down. Place them, again, in the rooms that they know they'll be in. But being able to have something they can just slip in their pocket, set it there by their phone or set it by their keyboard. Make it a nice color so it pops, but it's still easy to read. So if you're going to use don't use a super dark color of paper, use a lighter color with a bold font so that when they're busy, they can look and they're not constantly trying to find readers or something to read it. Here's an example, although this is too big, but these are examples of areas that often need a heads up or that they have to look up. And so I would not make it like this with 16 per se. Again, I wouldn't go over 10, 5 and 5, 5 CPT, 5 diagnoses, depending on the specialty that you're in. Most of the time, they don't need to pick their CPTs. They've got them, but not always. Annual exams, that's always perfect. The blood pressures, the obesity now being in class 1, 2, or 3. And then you can throw like tobacco counseling for cessation. And you need to make sure this shouldn't just say counseling to quit smoking, time-based code, 3 to 15 minutes need to be documented. So that little tips like that are going to go a long way. Another resource is to be a resource, not a critic. So don't tell them that they did something wrong. That is not going to build that relationship with your clinician. You're going to say, here's how we can make this chart bulletproof for the payer next time. Or I'm your coding resource. If you are ever unsure on how to document a complex procedure, just pop by my desk or send me a quick message and I'll assist. And make sure, again, when you do that, you're precise. They don't need anything flowery. Say, you know what, this is the description that I have of this diagnosis or this procedure. And I'm just going to outline these words that help me translate quicker and more efficiently. How do you propose to document that? And then you can suggest words. Again, share your courage, not your criticism. That's from Gary Hogg. Wrapping up here, the magic phrases that are going to assist you. And don't say, well, I'm just a coder. No, you're a part of the team, and part of your duties as a coder is to assist the clinician in helping them document so that you can translate properly. The scenario, missing specificity. The example is, Dr. Smith, your note is great, but to truly reflect the patient's complexity, Can we add one detail like uncontrolled or with anxiety to the patient's hypertension diagnosis if it's applicable? Now, there's different ways to query. These are things, though, that you could be stating to Dr. Jones. The medical decision making for this patient was extensive. If we add a note about reviewing the old records and weighing the risk of the new treatment, the documentation will match the level 4 care you provide. If you know that they did these things, you can do that, but you might rephrase it and say, when you are reviewing old records and weighing the risks of new treatment, if you document that thought process, you're going to be able to get a level 4 with your patients. Overcoding and vague documentation. The example is, I see we have a diagnosis for abdominal pain. To ensure medical necessity for the ultrasound is clear to the player, could you add a line about ruling out gallbladder or liver etiology, for example? Now, again, we cannot tell them what they're practicing or what they're looking for. But if you see that they were talking about this in the HPI and it's not in the AMP, then you can tell them, in the AMP where you're stating that, if we can please have more information to show your thought process. Okay. Now, again, these are not written queries. These don't follow the proper query rules. Find out what your query rule is. If you're sending them a message, how to query them properly. Build your query around this type of statement. You're not giving me the information I need to be able to code this particular scenario for this patient. So now let's talk about the summary. What have we learned about documentation? Some key takeaways and action items. Number 1, we're going to build the relationship first. If you get off on the wrong foot with your clinician, that being your doctor, your NPs, your PAs, then you're not going to have that team feeling. You're not going to feel like you're on the same team. And that's the goal, right? You're going to translate, not dictate. What's your role in the team? Make sure that your clinician understands the role that you provide and what you need from them so that you can do the job more effectively. Frame coding needs in terms of clinical accuracy and the patient care. Your patient population is really high risk. The documentation for E&M leveling that shows risk is A, B, C. If you document A, B, and C, then I'm able to translate that at a level 5 versus a 4 or a 3. We want to get to a 4 if applicable. Use quick hints, use games and positive reinforcement. That's always great. I used to always bring chocolate. Now, so many people don't do chocolate, but there's things that you could do. Maybe it's a sticker. Maybe you find out that your particular clinician loves to fish, and so you go out and buy them a fish hook, golden fish hooks, those little tiny ones. Say, oh, you get the golden fish hook today because of this great documentation I just read. Again, find out what they really enjoy and reinforce that. Be a consistent resource. Make yourself available for questions without judgment, and do not take too much of their time. Be very respectful of their time, and they'll be respectful of yours too. Most clinicians, not all of them, are type A personalities, and they're on the go. They're always moving, and they don't have time for chit chat. So celebrate the wins. Let them know when their documentation has improved. When you read something that's very clear, send them a thank you note. Positive feedback is always a powerful motivator. And really think about this. By becoming a physician's documentation ally versus enemy, you don't just make your job easier, you become an indispensable part of the revenue cycle team. And again, it is revenue cycle, coding and the billing and everything. Those are two sisters, and you're part of a team. And when you make it easier for someone on the team, that's going to go a long way. Thank you. Thank you, guys. That was so much fun. I'm going to stop sharing so that Laureen can jump in with her slide.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.